Ladies and gentlemen, welcome to this unique webinar entitled Value-Based Healthcare Platform Launch. We send you greetings from Geneva. We have a distinguished alignment of speakers that I'm sure you're going to enjoy. And I would like to begin by introducing myself. My name is Alex Mejia. As some of you know, I am the director of the Division for People and Social Inclusion and a great supporter of the Global Surgery Foundation led by Dr. Jeff Gibberson, part of our team. So let me try to give you a short introduction, and then we will project a video from our United Nations Assistant Secretary General, Mr. Nikhil Seth, that will portray perhaps even better what we aim to do today. Value-based healthcare platform will be a very distinct way to build capacity, to get information, and to add value to very many of you. So please allow us to go deeper into that. So officially, I would like to speak on behalf of our team at the United Nations Institute for Training and Research, and also on behalf of the Global Surgery Foundation, as I mentioned, to welcome you to this event. Why is this event important? Non-communicable diseases continue to be a major global health challenge. I'm sure most of you are aware that the WHO, the World Health Organization, estimates 41 million deaths each year due to NCDs, with 85% of premature deaths occurring in low and middle income countries. Adoption of the value-based healthcare approach can change that, combined, of course, with a strong surgical system, which is a foundation for treatment for most NCDs. In that regard, UNITAR and the Global Surgery Foundation are committed to facilitate locally led initiatives that will promote and advance the implementation of value-based healthcare in low-income and resource-limited settings. If I may, I would like to also mention that for more than 65 years, UNITAR has been the UN agency mandated for capacity building, mandated for capacity building, training, and research. The Value-Based Healthcare Hub aims to contribute to our efforts in building capacity to strengthen health systems, and indeed will support the local stakeholders and institutions in upscaling the great work that they are already doing. As we now move to the keynote address from our UN Assistant Secretary General, Mr. Seth, as I mentioned, I would like to commend the entire team on this excellent work accomplished in this regard, and particularly on the launching of this very unique value-based healthcare project. I want to conclude by telling you that the pathway forward has been well identified. Our resolve has been confirmed. There is much more yet to be done, but through working together with you, distinguished beneficiaries and participants, and also, if I may, again, I will address in more detail the speakers, but thanks to them and their support, we can indeed do teamwork, work together in a multilateral, multidisciplinary approach so we can achieve our goals. You will hear after Mr. Seth, Professor Rifat Atun. He will be properly presented right before he takes the microphone, but it's my great pleasure to consider Rifat a trusted colleague, someone that is actually guiding us with a very impressive resume that you are going to hear about. Then we have also Dr. Libna Samad, who's a great supporter of the Global Surgery Foundation as well, and a quite unique professional with experience in so many countries that will be introduced in a minute. Then Professor Chite Asirwa, medical oncologist and hematologist from Kenya, that will also be sharing his knowledge and expertise. And then Ms. Michelle Erwe, who is a global head of access to medicine at Takeda Corporation, a great partner of the United Nations and of UNITAR. We will watch the video now, and then I will take the floor again. Dear Nefti, please go forward.
Speakers and participants from around the world. On behalf of our team at UNITAR Foundation, we are honored to welcome you to the launch of the Value-Based Healthcare Hub. The aim of this new hub is to bring together leading academics, policymakers, healthcare providers, and cancer care specialists to firstly examine how value-based healthcare methodologies can be applied in their own country settings, secondly, develop locally appropriate plans, and finally, to implement these plans for improving healthcare through a value-based healthcare approach. The goal is to increase efficiency, safety, and finally improve the care that all patients receive from a country's healthcare system. The hub is also important because of how it was conceptualized. It is a collaborative partnership between a UN agency, that's us at UNITAR, a leading pharmaceutical corporation, Takeda, a premier academic center, Harvard Medical School, a Swiss foundation, the Global Surgery Foundation, and multiple frontline agencies such as the International Cancer Institute based in Nairobi, Kenya. This collaborative partnership exemplifies the spirit of SDG 17, which strengthens global partnership for sustainable development. One of the guiding principles of the initiative is to support the frontline leadership and facilitate their role in defining the pathway forward for their country's version of how value-based healthcare should be developed and acted upon. In Turkey, the leadership of UNITAR's National CFAL Training Center has taken an active role in bringing together the top academic clinicians of the country to take the process forward. It is with local leadership guiding the path forward that success will be achieved. Many may not be familiar with what value-based healthcare means in a practical sense. Indeed, the methodologies and concepts of value-based healthcare may be new to many frontline physicians. This further highlights the gap that our new hub intends to fill, bringing a greater understanding of what value-based healthcare methodologies are and how to apply them into clinical practice. Our distinguished speakers will describe how healthcare can be greatly improved through this process, but I would like to touch upon how this relates to the 2030 Agenda and universal health coverage. At the 2019 UN General Assembly, world leaders made a strong commitment to accelerate the progress towards universal health coverage, including financial risk protection and access to safe, effective, quality, and affordable health services. As countries strive to bring universal health coverage to their people, we have also been shown by healthcare leaders, policymakers, and academics that the methodologies of value-based healthcare can not only improve patients' outcomes, but also bring significant economic benefits while returning the focus on the patient through patient-reported outcome methodologies. As we begin the slow recovery from the terrible effects of the COVID-19 pandemic, the world has clearly seen the need for strengthening healthcare systems, making them more resilient in the face of such emergencies. However, even before the pandemic, there was a great need for establishing universal health coverage globally. UNITAR, through its capacity building efforts, is actively engaged in assisting the global community in addressing health-related challenges such as non-communicable diseases and poor access to surgical care, which together have become some of the leading causes of premature death globally. The value-based healthcare hub is another example of how we can assist countries in their efforts to strengthen their healthcare systems in an economically feasible way. Today's launch highlights our commitment to shaping local healthcare for universal health coverage. We hope to improve health outcomes in low-income and resource-limited settings by leveraging surgical care systems as a pathway to value-based healthcare. This project not only addresses SDG 3, good health and well-being for all, but also strives to contribute towards ending poverty, which is the first SDG. The long-term goal of value-based healthcare is making society healthier. The focus on preventing illnesses and providing efficient treatment translates to a population with fewer chronic conditions, helping them live productive lives. By choosing to focus initially on cervical and breast cancer, diseases primarily affecting women and girls, we were also guided by gender equality in SDG 5. In 2020 alone, breast cancer claimed the lives of 685,000 women, making efforts to combat the disease vital for improving women's lives and with it impacting entire societies. Both UNITAR and the Global Surgery Foundation are passionate about reducing inequalities. By including frontline implementers in country from the beginning, the hub aims to build local ownership and leadership to drive scalable and sustainable goals. At its core, value-based healthcare is about improving health outcomes for patients, ensuring that patients receive the best outcome from the healthcare they receive, while doing so at the most reasonable cost. At today's event, leading experts in the field will unravel this concept and discuss key principles and applications of value-based healthcare. UNITAR, along with the Global Surgery Foundation and Takeda, are committed to working with all stakeholders through this hub to achieve universal health coverage and championing progress towards the SDGs. I hope that you join us in this effort. Thank you very much.
We thank Mr. Seth for those introductory remarks and keynote speech. And before we go to the first of our speakers that will be properly introduced by our colleague Nefti, who will read their bios, I wanted to simply add two things. Number one, my respect to the Global Surgery Foundation team, Dr. Ibbotson, Sebastian Hofbauer, Nefti, and several other colleagues for putting this together. It's quite an honor to see how this new organization is taking its rightful place amongst in this ecosystem and amongst very prestigious organizations, number one. And number two, I invite all of you, dear participants, to read more about surgery standards, the need for surgeries, particularly in the developing nations, but also in very many other places. There is no exception to this priority that we have adopted. And in doing so, join us, be part of this effort. You are part of the solution as well. So you are invited, and we are very happy to have this conversation today. So we are going to begin the panel proper. At the end of the panel, Dr. Ibbotson will lead the Q&A. There will be some questions and answers that, depending on the time, we hope that we can answer, and then we will wrap up. So with that, dear Nefti, the floor is yours. Thank you.
Thank you so much, Alex, and welcome everyone. It's a pleasure to see you all. And it's my pleasure to introduce Professor Rifat Atim. He is Professor of Global Health Systems at Harvard University and also the Faculty Chair of the Harvard Ministerial Leadership Program. It's a program which supports world leaders and ministers with pivotal economic and human development related to responsibilities to exercise purposeful leadership and achieve transformative policy goals. He's also the Executive Board Chair of the Global Surgery Foundation and has an impressive resume with over 350 papers in leading journals such as New England and the Lancet. So Professor Atim, welcome. The floor is yours.
Thank you, Nefti. It's a real privilege to contribute to the launch of the Value-Based Healthcare Hub. I'm grateful to UNITAR and to Global Surgery Foundation for inviting me. I'm going to share my screen. Okay. So I'm going to talk about value-based healthcare, but very importantly, how one can transition from this concept of value-based healthcare to high-value health systems. Because many health systems around the world, not just those in low-income and middle-income settings, face major challenges, and these are shared challenges. Health systems are under pressure, especially in relation to management of chronic diseases and injuries. There is a very large amount of ineffectiveness, as we have been able to demonstrate recently, looking at cascades of care, where control of most of the chronic diseases actually are less than 30%. Health systems highly inefficient. 20 to 40% of health expenditures, WHO estimate, are actually not appropriately applied and could be used to generate greater value. Huge inequities. 5 billion people in the world do not have access to surgical care. This is 21st century, completely unacceptable. And there is inadequate responsiveness of systems to users and individuals and patients. Systems have been designed around structures as opposed to persons. And what COVID-19 has done is really has unmasked the health system's underperformance and revealed how inequitable health systems are and how these inequities are actually widening. But there's an opportunity, given that these challenges are huge. So there's an opportunity to transition to high-value health systems. So transitioning to high-value health systems, we need to ensure that the solutions benefit all. To date, value-based healthcare has focused on effectiveness and efficiency, sort of this notion of value for money. But I think we should, in transition to high-value health systems, we should also stress equity and responsiveness to user needs of the communities and countries, so we can achieve value for money, but also value for many. That should be the objective of building high-value health systems for all. And there are some important transitions that are happening that are catalyzing this transition towards high-value health systems. For example, in relation to health system financing, many countries have realized that the structural focus, where money follows provider institutions or inputs such as medicines and technology, has not led to the desired results. On the whole, the budgets tend to be historic and incremental, and they reflect the past rather than the current situation and the future. So many countries have transitioned to what I call a functional focus, where payment or remuneration reward follows activity through fee-for-service and payment for more aggregated services such as disease-related groups. Again, countries that have transitioned to a functional focus have realized that this has led to an inflation of activity, but without the commensurate improvement in outcomes. So now there's an impetus to transition to a value focus, where payment and remuneration follows value for achieving individual level outcomes of better health, better financial protection, and better user satisfaction and patient-centered outcomes, as well as population outcomes. So this transition to value is providing the catalyst to achieve high-value health systems. But for this to happen, a number of critical components need to be in place. The first and foremost is an interoperable and integrated digital data system with, where possible, appropriate analytics that enable performance benchmarking. So we know how each provider is and how the system is actually performing compared to past and relative to other systems. Secondly, we need to have a harmonized approach to measurement of cost and outcomes. So we can compare and contrast what is being achieved. Otherwise, one is comparing apples with oranges. Again, a second component is that systems for risk stratification, so that one can develop highly targeted approaches to populations and subpopulations. Third is bundled healthcare services, not the fragmented episodic care that currently prevails in so many settings. Fourth and foremost is person-centered integrated care pathways that enable the management of care across primary and secondary care and tertiary care, but also the interface of primary care with community and interface of healthcare and social care. Fifth is value-based payment models that rewards achievement of value, but also takes into account risk in relation to individuals, so that higher risk individuals that consume large amount of resources are able to achieve appropriate services with appropriate remuneration. And very importantly, ecosystem for innovation, adoption, and diffusion. Pushing new solutions into broken systems will not achieve the results. We need to create an enabling ecosystem for rapid adoption of these innovations. And also in this ecosystem, develop tools for cross-learning. And this is one of the important functions of the hub that is being created. And to enable all of this to happen, one needs to achieve a strategic change, both in providers and payers, as well as users of the system. because transformation to value-based health systems will achieve major shifts and change in the design of health systems. So value-based healthcare is not just a single solution. It's really a whole continuum for innovation, and this is what is so exciting. So one can create value, use as an entry point different approaches. For example, one could use a therapy or what we call a therapy plus solution, an intervention with a service component, or one could focus on an episode of care, for example, a surgical procedure or medical procedure, or a single disease, for example, management of diabetes or hypertension or cancer, or one could focus on a multi-disease bundle, for example, cardiovascular disease or series of surgical conditions, or even focus on population level. And one could look at the outcomes achieved over time, over different periods of time, so in weeks, months, or even years. And there are examples of these innovations emerging. For example, in Catalonia, Spain, use of cardiac defibrillator implants with a service component for therapy plus example. In terms of episodes of care, many examples. For example, in Sweden, in Stockholm County, spine, hip, and knee surgery. In Uppsala, use of multiple care pathways. In Portugal, cataract surgery across a whole network of providers. In Sweden, through Sphere's initiative, many of these interventions are being taken up to the rest of the country from the initial experience of Stockholm County. And in relation to single disease, in the Netherlands, there is Diabetes that is focusing on diabetes, achieving really excellent outcomes, or approaches for management of atrial fibrillation. In Spain, last week, I came across an interesting example in management of aortic stenosis, or in the UK, management of atherosclerotic cardiovascular disease, again, focusing on a specific condition. In terms of multi-disease bundle, again, interesting emerging examples. For example, in Ontario, Canada, management in South Lake Hospital, management of a whole cardiovascular program. And at population level, in the NHS England, actually England was one of the, or the UK was one of the major proponents or value-based approaches as long as 25 years ago. And the quality and outcomes framework, both for primary care and hospitals, is enabling a focus on achieving output, desirable outputs and outcomes. And finally, in Valencia, in Spain, the Alzira initiative enabled a contract with a provider that took care of the whole population over a multi-year period. So there's an opportunity for innovate across this continuum of different intervention bundling and looking at outcomes over time. But before introducing value-based healthcare, one really needs to understand the readiness of countries. And this is an exercise led by the Economist Intelligence Unit. And I had the great fortune of being one of the advisors on the study, which goes back now a few years, where we assessed country readiness for value-based healthcare in a number of low, moderate, high-end, in a number of countries. And as you can see in the low and middle income countries, such as Brazil, Chile, China, Egypt, India, Indonesia, Mexico, Nigeria, Russia, in fact, most of this list, plus others, they tend to have low preparedness. So this ecosystem doesn't exist. And those countries that have high preparedness, where sort of UK and now Canada, or Sweden, Denmark, Netherlands, and Catalonia in Spain. So we need to think about investing to develop enabling ecosystems for introduction of value-based healthcare. So how do we do that? Well, to create an enabling context for value-based healthcare, I propose the 5 C's. The first is consulting widely, jointly identifying system challenges. Critically important to involve civil society and patient groups in this, because we need to solve the problems for them, as opposed to just for healthcare professionals or payers. Second, using data and analytics and performance benchmarking, challenge current practices to understand where performance is in relation to what might be achievable in a particular setting. The third is co-production, co-design, and co-implementation of solutions involving multiple stakeholders, very importantly, patients and service users. Fourth, changing the system design through strategic change. This is critical. Pushing more solutions into systems that were designed hundreds of years ago is not going to achieve the outcomes. As Einstein said, insanity is doing the same thing over and over again and expecting different results. So we have to completely rethink system design and use value-based healthcare approaches to achieve that. And finally, create an ecosystem for innovation. So in local contexts, innovations are generated, implemented, and diffused. And especially in low and middle income countries, innovations are not just imported from other countries. So there's this incredible opportunity to transition to value-based health systems through application of these 5 C's. But this is not easy, even in highly sophisticated systems such as Sweden. This is a study we published recently in Social Science and Medicine examining value-based healthcare introduction in Sweden and Brazil. We noted the challenges of adoption and scale-up, where it proved difficult to actually institutionalize the value-based healthcare approaches because there was undue emphasis on change. There was too much emphasis on sort of top-down approaches to push solutions into systems. And we concluded in this paper that an effective value-based healthcare transformation seems to require a systematic and systemic approach where all stakeholders need to clearly define the purpose and the scope of the transformation, and together steer their actions and decisions accordingly. So my final slide, in transition to high-value health systems, we need to now move from concept to content. I think we all agree that creation of high-value health systems is desirable, given the challenges we're experiencing and the huge impact of COVID-19. So we need to generate local solutions and learn from them. Secondly, we need to transition from general solutions, but actually context-sensitive innovations. So we need to have not just one model that is imported from one setting to another, but actually locally generated innovations that are context-sensitive and context-specific, taking into account of the principles, but all the critical components that I talked about. Third, and very importantly, moving from value-based healthcare to high-value health systems requires a transition from what I call boutique cases in one institution to critical scale. We need to scale up innovations to achieve not just value for money, but value for many. Otherwise, many will be left behind again and will widen the inequalities further. And finally, time has come to move from tactical projects, again in boutique cases, to the strategic investments in the platforms and the critical components that will enable us to transition from value-based healthcare to high-value health systems. So what is very exciting is that the new hub will provide a catalytic role to do this in an inclusive fashion, and I feel very privileged to be part of this initiative. Thank you.
Great. Thank you. Can you hear me now? Thank you very much, Professor Atun, for providing such a great overview and about really creating not value for money, but value for many. That's something that will definitely stick with me, and I hope with all of our participants listening as well. So next up, we have Dr. Libna Samad. So she is the director for the Center for Essential Surgical and Acute Care, and she's also a pediatric surgeon at Indus Hospital and the Health Network. On top of that, she is also part of the Global Surgery Foundation leadership team. She's committed to improving patient outcomes and with a specific focus on lower and middle income countries. And she's working with teams in campuses across the country to improve surgical care delivery platforms and patient outcomes. Dr. Libna, the floor is yours. Thank you very much.
Jeffrey, thank you so much. I think I am enjoying this session almost as a participant more than as a panelist, because Dr. Atun's talk was so enlightening. And as we go further down the slide set, I think it will explain why I'm particularly excited about this initiative. So it's really important to understand why, global surgery has become a buzz. And that is really in the past few years. And that's really because of the untiring efforts of a very large group of people who have tried to build the momentum and educate policymakers, surgeons, anesthetists, and governments to understand that surgery is not something that starts and ends in operating rooms. It is just like maternal health care, just like NCDs, it requires a system an ecosystem that supports surgical care and that allows that platform to be utilized to improve health in general. So this was recognized to be a major gap in the global health development constellation, and therefore surgical care and surgical systems have become increasingly important in the global health world. We believe that strong surgical care systems form the backbone of strong healthcare systems. And as we've been going down the implementation of the essential package of health services in Pakistan, particularly, which is the example that I'm most familiar with, we've realized that surgery has a role to play in every disease cluster, in every specialty. Surgery has a role. And that's what those little boxes down there are showing. You think of it, surgery has a role, from NCD to cancer treatment, to road traffic accidents, to trauma care. Surgery forms the cornerstone, an important pillar of providing care in all these clusters of health service delivery. And most importantly, as we've realized, that during pandemic, this current pandemic phase that the world is going through, wherever there are strong surgical systems, they are able to support and provide a system whereby the COVID response is more coordinated. Just because the need for critical care, the need for anesthetists have supported COVID critical care ICUs across the world during these past 2 years. Next slide, please. We know that as the efforts to decrease the prevalence of communicable diseases, including diarrhea, HIV, malaria, TB, typhoid, have reached successful levels, immunization is probably the one biggest thing that has impacted the incidence of communicable diseases. We concomitantly realize that NCDs are increasing at a rapid pace, and we're all familiar for the reasons for that. And as we saw in the previous slide, surgical care forms a pillar in the treatment approach to many, if not all, non-communicable disease conditions. Next, please. And again, the emphasis of why surgery, it's the sheer number. 30% of the global burden of disease is amenable to a surgical intervention, be it a cesarean section, be it surgery for removal of a Wilms tumor, which was what I was doing this morning, or any other condition that requires surgical intervention, means that this is adding to the global burden of disease that is amenable to surgical care. However, because we have traditionally looked at these conditions in their compartments of maternal child health is where a C-section happens, and oncology or cancer care is where oncological surgery happens, we don't look at all these requiring one common thing, and that is a surgical platform and a surgical system in order to support this intervention. The economic impact is huge, and we have to realize that these surgical systems are adaptable and can provide a system that supports any crisis, emergency, disasters, earthquakes are all going to be helped by having robust surgical systems in place. Now, with the next slide, I'm going to talk about why the value-based healthcare initiative by GSF, Takeda, as well as UNITAR is so close to my heart. About 5 or 6 years ago now, I think this is 2015, at the Indus Hospital in Karachi, Pakistan, where I live and work, we partnered with the BGSSC team to map the process of knee replacement at our hospital, to estimate the cost that was incurred, and to identify what were the system-related inefficiencies, including cost, time, resource utilization, to estimate what it cost the patient, and then to assess the patient's quality of life, both before and after surgery. And this is published in the BMJ Open as well. I think this is about 3 years ago that this was published. The next slide, please. And what we realized that the total cost for a total knee replacement at our hospital amounted to $4,360 US, with an additional $564 cost that was borne by the patient. And we need to realize that this $564 is a huge amount in a country like Pakistan, where a third of the population is living below the World Bank threshold of poverty. And then we could I have the next slide, please? We went through the system and realized that a major cost of component was the cost of the knee implant itself, almost 40% of the cost. And another factor was the 14-day length of stay. Now, just based on this, we were able to do a very quick cost-saving intervention by putting in physiotherapy that was home-based, providing a helpline to the patients, providing an exercise video at the time of discharge, and providing brochures for both pre and post-surgical information to patients. And this, by reducing the length of stay from 14 to 6 days, we were able to have a cost savings of over $730. Now, this again was just by doing one step. And as we've seen in other hospitals, especially the Narayana Hospital in India, the cost of knee implants and the cost of surgical equipment can be reduced significantly by doing volume purchasing. And there are so many examples across the world where surgical costs have been reduced just by identifying where the system hurdles lie and by overcoming them. However, what we did realize during the course of this one project is that it requires more resources and processes than we have in place in an LMIC setting like ours. And therefore, just seeing all those challenges and issues highlighted in Dr. Atun's talk today really made me very happy, because this is something where we hit a bit of a roadblock. We couldn't progress further because the ecosystem was not there. We did not have an NSOAP like 8 processes highlighted. And I think that is what is needed to get support going so that these projects, very small projects, can be translated into scaled up systems where costs of care are reduced significantly. Next, please. So the Global Surgery Foundation is committed to providing or supporting this ecosystem by leveraging surgical systems as a pathway to value-based healthcare. And again, the importance of developing clear outcome measurements that are focused on the patient. For example, if you do a total knee replacement and the X-ray looks fantastic, that doesn't mean anything until the patient can return to walking on an uneven pavement in a low-income setting in Karachi. And that is what is important. How does the surgery affect and impact the life of the patient? It is important to build an understanding of the principles of VBHC at all levels, from policy through to hospital administrators, through to surgeons and health providers. And then again, build an ecosystem of key stakeholders that can all contribute to making this happen. As part of the leadership team at the Global Surgery Foundation, I am excited and committed to making sure that this is a success. I think that was the last slide. Thank you so much.
Thank you so much, Dr. Libna, for sharing, actual implementation of value-based healthcare in Pakistan, but then also telling us about GSF's commitment to value-based healthcare and also focusing on the role of surgery and strengthening surgical systems. And it was great to hear from you, and thank you so much for joining us. So next, we have Dr. Chiti Asiwa. So he is the CEO of the International Cancer Institute, which is an organization whose main purpose is to expand education, clinical care, training and opportunities in cancer control and research across sub-Saharan Africa. So he's really at the front lines, and he's done many projects, one of them being the blueprint for innovative access to healthcare in Rwanda, and he's done a lot of work in sub-Saharan Africa. So I'll hand over to you now. Thank you very much.
Yeah, thank you so much, and I'm very glad to be here. Very nice presentations that I've already listened to. So I'll go straight to the model that we International Cancer Institute uses, and I really like this discussion because we are really talking about integration, and there's no place where integration of services needs to be more emphasized than in low and middle income countries, because more often enough, we do not really have those resources to go around, whether it's infrastructural resources, human resources, or otherwise. And so we put the clients and the patient, the communities at the center of all our programs. And if you look at the integrated programs, you have education and training, noticing that all this has to be done both at the community level and the healthcare professionals level, because it doesn't really help very much to have a very learned community, and when they come to the hospitals, the healthcare professionals do not really know what next steps to be done. And then we do community screening and early detection, which, and this is where surgery really is important. If we can get really as many of these patients, whether it's breast cancer and even quite a lot of these solid tumors, get them at early stages so that they're amenable to surgery with potential curative intent, and therefore not spending a lot of dollars in improving outcomes as well. Then optimal diagnostics, we centralize some of these diagnostics with hub and spoke, where we have some centers that we build to ensure that, like with digital pathology platforms, that becomes the hub, and various spokes from the various centers to improve efficiency, to share resources, but most importantly, to also improve referral patterns. As well, we also have access to therapies. You can do all these things, and in the cancer space, if we don't really have concerted efforts from the policy level and all the stakeholders in terms of how to access those therapies, as well as palliative care. So we have something that we call revolving fund pharmacy, as well as access to medicines program. And then data. We've already had this from the previous presenters. We have to measure the outcomes. We have to measure everything that we do. Creation of platforms that share this data is important. And as part of Blueprint, we actually recommend in most of these sites the use of electronic medical records, and working very closely with various players to put data points that we can actually measure. We also have telemedicine that improves the relationships between sites, but also decreases the time that it takes in terms of delay to diagnostics as well as to care by sharing the few resources we have, especially human capacity. One of the other things I've noted, especially in global oncology work, is the leadership component, because we really need to have a lot of consensus. And I really liked the discussion where we are talking about consultation widely. The consultation widely is actually based also on trust, not only with the local partnership, but also with the government, the non-governmental organizations, the women group, the survivors, and several other partners. And this kind of partnership and advocacy is both at the implementation as well as the funding level. And then we've been working very closely with survivors. If you want to know a person that has gone through the entire system, especially for cancer care, no better person than those who are surviving from the various cancers, and obviously as we do surveillance. So we have this integrated approach in terms of improving care, as well as improving the pathways to care and referrals. So Rwanda, as an example, we've been doing this Blueprint program. We've done it in Meru over the last 3 years. and we have some success stories that we have a manuscript that we are publishing. However, in Rwanda, we started engaging stakeholders in August of 2019, and these are the various stakeholders that were in the first meeting. As you can see, just sharing some of the pictures of that meeting. A key recommendation at the time, Rwanda did not have a national cancer control program, and it became very hard to really organize the concerted efforts of various key players within the cancer spectrum. And so this was actually established in 2020 by the Ministry of Health in Rwanda. We held another engagement session where we had several other partners, Human Resources for Health, involvement of policymakers, academic institutions, patient groups, the hospitals, the various key players is very important. And in this, we had a needs assessment done. Local implementing partners were identified, implementation strategy was discussed. We had a technical working group that was suggested, and we recommended a partner summit, where now we do another stakeholders. I don't really think we can overemphasize in terms of really getting commitment as well as consultation widely from the various stakeholders on the ground for any of this implementation, and especially if you want to really utilize the little resources to ensure that you are improving and increasing the outcomes. And so with this last major stakeholder involvement in October of this year, we had 5 districts identified, technical working group formed, and we have initiated various programs in various centers, including from breast and cervical cancer screening, as well as prostate screening. We are looking at it from the entire patient continuum, the patient journey, where you have early detection, as well as screening, optimal therapeutics and diagnostics, palliative care, survivorship, as well as research, and obviously data and several other components are cutting across the board. An important resource mobilization, but also looking at who is going to be payer source for these activities that are being done. So creation of the system, this is part of the technical working group that is doing the blueprint in Rwanda. And what are we looking at as our impact statement? Our impact statement is that the blueprint for innovative access to healthcare program seeks to improve survival and quality of life for people impacted with cancer and NCDs by strengthening high quality, integrated, and consistent local healthcare capacity and capabilities across the patient journey. And you can see quite a number of these wordings that are part of this impact statement is actually what value-based healthcare is all about. And if you look at some of the integrated approach that you do for those patients or those people who are coming for screening programs, we've integrated with hypertension, diabetes, to be able to, because one of the things we look at in our setting is that if I do cervical cancer screening or I detect it early, and I prevent one woman from dying from cervical cancer, but they die of stroke, they are still dead, and that is really not value for the programs and the system. So our work is to ensure that we are strengthening the system across board and bringing as many players as possible. There are several key components. I've already mentioned this, involvement of various leadership and various policymakers. We have donor support from Takeda Pharmaceuticals, and we have several implementing partners on the ground, as you can see. But there are potential additional partners, including the UNITAR, GSF, Chai, Roche, and several others that we are working across. I won't mention so much about the healthcare system delivery, but this is not very special to Rwanda, but most of the low and middle income countries have such kind of a system. As I said earlier, stakeholders and a lot of capacity building is very important. This is part of our leadership of our program. Our core domains is to look at capacity building, something that is actually very strong in sustainability measures, training across all cadres of staff. We encourage a lot of multidisciplinary team approach in terms of cancer care that improves efficiency and improves referral within the system. Coordination of these services. One of the things we've learned even from the patient survivors as well as the caregivers is the fact that patient navigation through these complex systems, especially for cancer care, can actually really help reduce redundancies and inefficiencies within these systems. Pathology is very huge in our setting because without pathology, we don't know what we are measuring and what we are doing. It's actually the entry point into cancer care, and enhancing those diagnoses so that we are doing personalized care would actually really improve the outcomes and obviously the responsiveness of the system. And we do community linkages to care. So it's not enough. And I always say, don't screen if you don't really have the back end of how those people will be screened. If they need to get some care, how are they going to access care? And so this is very important for linkages to care. Data is important, cancer registries, and obviously implementation science. quite often enough, the challenge is in our settings, there is no current practice for quite a number of aspects. And so we are not only establishing current practice, but we are simultaneously looking at what are some innovative ways of actually bringing out that practice to improve outcomes on a dime using this value-based healthcare. Then obviously drug accessibility and sustainability of projects. One of the most important things I've realized in our settings, especially for cancer care, is the virtual tumor boards. Initially, our virtual tumor boards used to have 40 clinicians attend. Now we have more than 800 attending each of the two virtual tumor boards every week. And so this is a huge platform to improve the quality of care across several regions without having people necessarily needing logistic support to go to those areas. I'm not going to mention so much about expected outcomes, but they are dependent on some of the activities we are doing, capacity building being huge, and also access to care, improvement of referral patterns, diagnostics, and being able to measure the outcomes so that we can say, what is really the impact of this and how can we scale this up? It's only scalable if it's measurable and some impact it can be seen. So thank you so much. I'll stop there and hand back over to you.
Thank you so much for talking about the role in cancer care, and especially within the context of Kenya. And thank you also for emphasizing the role of strong stakeholder engagement and a team-based approach, which is a key component of value-based healthcare. And thank you very much for your time and sharing that with us. Excuse me. I'll just share my screen, apologies. So up next, we have Ms. Michelle Earley. She's the Global Head of Access to Medicine at Takeda, where she's responsible for accelerating patient access to Takeda's highly innovative medicines in underserved communities. She has spent the last 13 years at Takeda in various leadership positions across sales, marketing, and general management. Her career spanning over 25 years in the health industry has taken her across the globe from Africa and to Middle East and Asia. Michelle, please, the floor is yours. Thank you very much.
Thank you, Nefti, and thank you to our esteemed panelists and our audience. It's really a great opportunity to be here tonight or today or this morning, wherever you might find yourself. So next slide, Nefti. So at Takeda, please allow me to provide you a brief introduction as to who we are at Takeda. So at Takeda, we take a lot of pride in how we deliver on our purpose. And our imperatives is focused around our patient, our people, and our planet. And very importantly is our foundation is made up by our values of Takedism. And this is brought to life in how we make our decisions in a daily basis with what we do. Centered, and it starts with the patient, then trust, reputation, and business. Next slide. So we've highlighted and we've heard from our panelists tonight is the increasing burden that we have with non-communicable diseases. And we also see the increasing trend of that of an aging population, as well as the increase in life expectancy, together with the burden of non-communicable diseases and the pressure that this is creating on our healthcare systems. Today, more than 70% of deaths globally is contributed to non-communicable diseases. Next slide. We're also seeing a rapid increase in health expenditure. And this is outpacing our GDP growth that we have within our countries. And we know that this is not sustainable. And for this reason, it is calling us to action. Millions of people, inclusive of patients and their families, every year is pushed into poverty as they try and manage the effects of non-communicable diseases. Next slide. So we have also heard tonight about the many inefficiencies that we see across our infrastructures, and our health systems. And for this reason, we are called to action in addressing this. Next slide. So at Takeda, we define value-based healthcare as a multi-stakeholder collaboration. So please allow me to elaborate more about what do we mean with collaboration. Collaboration for us encompasses the co-creation of working relationships or partnerships which share a common vision, engagement, and responsibility for outcomes, and to provide a meaningful value for patients and society by delivering innovative health services and technology in a sustainable and equitable way. Next slide. So we've now acknowledged that we have many challenges and barriers. And for this reason, we are partnering with UNITAR, because we know that by collaborating, we can pool our resources, achieve a common goal, tap into the know-how to overcome these barriers. And our key objective is to improve health outcomes, as well as the policy development towards value-based healthcare. Next slide. And lastly, is to remain relevant. We believe that it is a unified approach across the stakeholder segment, which is essential inside the industry, outside the industry, to collaborate as one to address these barriers, but also to share in the value creation that this brings to enable that we can make a difference. Next slide. So in closing, just to say is that as Takeda, we are committed to a better health and a brighter future. And I thank you for the opportunity that we have with our stakeholders to continue to try and make a better health for the patients out there. Thank you very much, Nefti.
Thank you very much, Michelle, for joining us today and for sharing all that information. We're really excited to be in partnership on this project with Takeda and developing these pilot projects to hopefully guide how to implement value-based healthcare in practice. And next, we will have Dr. Jeffrey Gibberson. So he's the Senior Health Advisor at UNITAR and also the Executive Lead of the Global Surgery Foundation. And he will tell us a bit more about the platform itself. Thank you.
Thank you, Nefti. Well, I just want to go through quickly a bit of a summary of what we've heard today. It's been a great session with some great speakers, and each one of them touching on certain aspects of what value-based healthcare really means and what it is. Just to remind you, Nikhil Seth talked about that relationship with the SDGs and universal health coverage and how important these approaches are to achieving that goal of universal health coverage. Then Dr. Rifat Atun gave us the broad picture of what value-based healthcare should be, the value for many, and then bringing into that the discussion about patient-centered care in that context. It was great to hear from Libna Samad and her experience of that intersection of surgical care and in Pakistan, the value-based efficiencies in that care, as she described. Very importantly, what Dr. Chitte had described in his work in Kenya and what we're looking towards in Rwanda is very interesting and very, very important, because the frontline stakeholders have to be the ones taking the lead and setting the priorities. This won't work if it's a top-down approach. It has to be led by the frontline stakeholders like Chitte. And Michelle, thank you so much for your insights, because the reality is we have to do this together in a consortium. It can't be just one or the other, and having industry as part of this is an integral part as we move forward to success. So as we look at this whole session, it's clear that value-based healthcare and the patient-centered approach to monitoring and improving outcomes is a clear pathway to assist countries in their journey towards universal health coverage. The hub that we're creating and being launched today serves to help that process. And we want to take lessons learned from other high-income country experiences, such as the Health Outcomes Observatory process in Europe, and adapt those lessons to lower resource settings and allow those countries to take the lead in contextualizing what we found work in the H2O program. The first projects will be set to begin in Turkey, Rwanda, and South Africa. And we want this process, as I say, to be led by the frontline stakeholders and not a top-down approach. Next slide, please. The hub will serve as a focal point and a repository for resources to facilitate those countries in their efforts. The website of the hub will grow and evolve over the upcoming years. And so please check in regularly to see these updates on how it grows. Now, finally, NCDs, as we have already heard, have become a major global burden of disease. And likewise, cancers, such as breast cancer and cervical cancer, have become major challenges for LMIC countries. Surgical care systems are really the mainstay of comprehensive treatment for these diseases, and yet, as you've heard, are unavailable to the majority of people in low-income settings. As we strive to achieve universal health coverage, the value-based healthcare approach and working to increase access to strong surgical care systems offers tangible solutions that will help us get closer to our goals. With this launch, we also want to make a call to action for other stakeholders to engage with us. By working together, we are more likely to realize our goal of universal health coverage. The pathway forward has been identified, and yet on that pathway, there are also many challenges. But I'm really convinced that by working together, we can overcome these challenges. I want to give a special thank you to all of our speakers and all of the participants that watched. I think we're on the beginning of a very exciting journey moving forward, and the opportunities ahead of us are enormous in making difference, particularly in countries where they're struggling the most. Because at the end of the day, I think value for many is the key take-home message of today's presentation. And in that ethos, leaving no one behind. So with that, I'd like to thank everyone for joining us. I'd like to thank our speakers, and a special thank you to United Nations Institute for Training and Research, Takeda, and the Global Surgery Foundation for this joint commitment to make a difference in the world, aiming towards universal health coverage. Thank you very much, and have a great day.
Thank you.